to invite Asanka to the podium.
Thank you, Dr. Kanchana, for the kind words of introduction. So, my lecture is on how to work out at a diagnosis when a patient presents with joint pains. So, this is actually a basic lecture intended for the first contact doctors. And what I do is like to recap what we've learned at med faculty and to show you how to put it into practice. So, coming to a diagnosis is basically a pattern recognition, like connecting the dots. So, when a patient presents with coming to a diagnosis is basically a pattern recognition. So that is connecting the dots. So when a patient presents with joint pains, there are certain factors that we must pay attention to in order to draw dots. So first thing is we have to determine whether the pain is actually arising from the joint itself or whether it's arising from the periarticular structures, because as we know, joints are complex structures involving many tissues. So there's bone, articular cartilage, synovium, joint capsule, ligaments, tendons, bursae, and so many. And once you've determined that it's coming from the joint, then we need to evaluate whether we need to find out whether it's actually predominantly inflammatory or non-inflammatory. So I'd like to say, like, it's better to think of it as predominantly inflammatory, since even the degenerative arthritis can have some component of inflammation. So next thing that we must pay attention to is the temporal nature of the joint involvement, whether it's an acute one, whether it's a chronic one with episodic worsening, or whether it's an episodic sort of joint pain. And then we must look at which joints have been involved. So basically how many joints, or whether it's just mainly small joints of the hands, or whether it's large joints of the lower limbs, whether there are many joints or just a few joints. So that would also help us come to a diagnosis. Then we must look at other associated features like skin rashes, bowel symptoms, and so on. And then finally we should come to the appropriate investigations. So what I'm going to do is like to discuss each and every topic under cases. So the first case is a 26-year-old hairdresser who presents with a 1 month history of right index finger pain with worsened pain on flexion of the finger. So she points to the proximal interphalangeal joint as the site of pain. But then we must feel the joint to see if the pain is actually coming from the joint. So how do we feel for the proximal interphalangeal joint? We slightly flex it and then apply slight pressure over the posterior lateral aspect of the joint. So here we don't find any tenderness there. So we work along, then we examine the rest of the finger and then find there is tenderness over the palm aspect of over the metacarpophalangeal joint. So we may in this case find tender nodule. Patient may sometimes complain of triggering of the finger. So that is a flexotenosynovitis. And then the patient also has right wrist joint pain worsened when using the scissors. But then there is no actual tenderness of the joint line of the wrist joint, but there is tenderness over the radial styloid. So pain can be elicited by passive stretching of the abductor pollicis longus and the extensor pollicis brevis tendons. Those are the tendons lying over the radial styloid. So here we see in this patient. So if you hadn't examined this patient properly, you would think it's arthritis involving the joints. But here it is actually flexotenosynovitis and a recurrence tenosynovitis. So the management here is very simple. You give analgesics via steroid injection and maybe splinting. So how do we differentiate whether it's articular or periarticular? So articular pain is mainly pain on movements in, you get pain in movements in all directions, whereas in periarticular structures there is pain on specific movements. So in articular pain, the pain will be there in both active and passive movements, whereas in periarticular structures the pain is mainly with active movements and also can elicited with passive stretching. Tenderness mainly over the joint itself when it is articular structures. When it is periarticular structures, the tenderness is outside the joint line. And swelling again is when it's articular structures, it will be on the joint itself, but in periarticular structure pain, it will be around surrounding the structures which are involved. So what are the causes of periarticular pain? So it is it can be tendinitis or tendinopathy, enthesitis or enthesopathy, fasciitis, bursitis. So common tendinitis and enthesitis actually is tendinitis, dequens tenosynovitis as in our first case, and supraspinatus tendinitis, bicipital tendinitis presenting with shoulder pain, and then flexotenosynovitis, then epicondylitis and plantar fasciitis. So I'm not going to go into details. It's just a basic lecture to touch upon these topics. So in epicondylitis, the patient may complain of elbow pain, but there will be pain on specific movements and the tenderness is over the epicondyles. And actually tendinitis, the patient may complain of ankle pain, but then the pain may be the tenderness and will be over the Achilles tendon. So it could be either insertional tendinitis, where the tenderness will be elicited at the insertion of the tendon, and there is mid portion tendinopathy, and pain is surrounding the tendon. So bicipital tendinitis, the way tenderness over the anterior aspect of the shoulder joint, and here in this picture that's showing that trying to elicit pain by resisted supination while the elbow joint is flexed. So there are certain maneuvers that we can perform to determine whether it's coming from certain periarticular structures. So supraspinatus tendinitis showing the classic painful arc. I'm not going to go into the details on this. I believe we already had a lecture on shoulder joint pain and evaluation. Then there are common bursitis like subacromial subdeltoid bursitis, Nanserine bursitis, trochanteric bursitis. So here the first picture showing Nanserine bursitis just medially below the knee joint line. Then trochanteric bursitis, patient present with hip pain. The pain is actually elicited over the tenderness is elicited over the trochanter, greater trochanter, and then subacromial subdeltoid bursitis, where the pain is at the lateral aspect of the shoulder. So second case is a 54-year-old lady coming with bilateral knee joint pain for 3 years duration, worsened pain for 1 week. So there is episodic worsening of the pain with a history of mild swelling at times. So there is a pain where her pain is worse with activity, and she doesn't have any other systemic symptoms. So on examination, there is reduced range of motion with crepitus. So tenderness at the medial aspect just below the joint line at the site of the Anserine bursa. So her inflammatory markers are normal. So this is mainly predominantly non-inflammatory type of a pain. So this is osteoarthritis. So if you look at the X-rays, it will show something. This is the X-ray of an advanced osteoarthritis actually. So so what are the features that we should look for to determine whether it's predominantly inflammatory? So in inflammatory arthritis, there will be marked tenderness and swelling. There may be erythema and raised temperature on the joint. There will be early morning stiffness. It is significant if it is lasting more than 30 minutes. And then the patient will complain of stiffness that eases off with exercise. And the inflammatory markers will be elevated, and the patient will show good response to NSAIDs. So if a patient who's coming at an age below 40 years, then we have to sort of think of predominantly inflammatory arthritis. So just to touch upon the types of inflammatory arthritis, so septic arthritis, rheumatoid, maybe spondyloarthritis, and arthritis associated with systemic rheumatic diseases, crystal arthritis, and reactive arthritis. And then the non-inflammatory arthritis is the osteoarthritis, but there also we can have some degree of inflammation, especially associated with flares. So the next patient is a 60-year-old male with diabetes mellitus. There's acute pain and swelling of the knee joint for 3 days duration. There is marked restricted movements with warmth to touch and an effusion. And there is also fever. So in this case, it's a monoarthritis and acute onset. So here we have to exclude a septic arthritis. So that is the main first thing that we must do in this situation. So the other possibilities is hemarthrosis, then it can be crystal arthritis. Gout and pseudogout can present with similar features as septic arthritis. And reactive arthritis can present with monoarthritis like this. And sometimes the first presentation of chronic inflammatory arthritis like spondyloarthritis and rheumatoid also can present with similar findings. So first thing in such a situation is to exclude a septic arthritis. So you need to aspirate the joint fluid and send for full report and culture. So if you are suspecting possibility of either a gout or a pseudogout, we can send a fresh sample for microscopies, polarized microscopy if available. But if that is not available, we can discuss with the pathologist and they will look for the crystals. They will not be able to identify which crystals, but they can identify with the look for the presence of crystals. And we have to arrange for full blood count CRP to assist us with the diagnosis. So the next case is a 42-year-old male patient with diabetes mellitus, hypertension and dyslipidemia, who's coming with a history of episodic acute pain and swelling involving various joints at various presentations. So the involved joints are first metatarsophalangeal joint, ankle joint, knee joint. So this swelling is sometimes swelling and pain which settles well within a short period, and it's sometimes associated with redness of the overlying skin, and it shows good response to NSA. So most of the time patient says, I take a diclofenac when I get this pain, so pain and swelling, so it settles over about 2 to 3 days. So this is sort of showing a picture of involvement of the first MTP joint. So the history is typical of gout. The other things that we have to consider when a patient presented with a palindromic type arthritis is gout and pseudogout, but pseudogout is mostly commonly seen in the elderly. Mainly the wrist and the knees are involved, but then young patients with metabolic abnormalities can present with pseudogout at early ages. And then palindromic rheumatoid arthritis can present with this episodic arthritis lasting a couple of days. And sometimes connective tissue disease associated arthritis like SLE can present with a similar picture. So this is the temporal nature of arthritis, so that is important when coming to a diagnosis. So there's acute arthritis. So acute arthritis is, as we discussed earlier, septic arthritis, crystal arthritis, and like rheumatoid arthritis. Chronic ones is osteoarthritis, even chronic inflammatory arthritis like rheumatoid and other inflammatory arthritis can present as chronic arthritis. Then the episodic nature, as we discussed, gout, pseudogout, palindromic RA, and connective tissue disease associated arthritis. So the next case is a 45-year-old lady without any comorbidities, presenting with pain and swelling of small joints in the hands, knees, and elbows with morning stiffness of 1 month's duration. She also has fatigue. So on examination, there is swollen and tender metacarpophalangeal joints, proximal interphalangeal joints, and knees. So rest of the examination is normal. She has raised inflammatory markers, mild anemia, and a positive rheumatoid factor. So it's clear it's rheumatoid arthritis. So it's a picture showing swollen metacarpophalangeal joints and spindling of the fingers. So what are the differential diagnoses with this? So it's rheumatoid arthritis, systemic rheumatoid disease associated arthritis can present like this. Psoriatic arthritis can present like this, but the metacarpopharyngeal joint involvement is less like in psoriatic arthritis. We would expect more of a distal interpharyngeal joint involvement with the PIP involvement. And viral arthritis can present with the similar clinical picture. So the management is just to touch upon it. What you have to do is with rheumatoid arthritis, the early diagnosis and initiation of DMARDs is actually essential for a better outcome. So when you come into contact with such a patient, better to refer to the rheumatologist as soon as possible to start the disease modifying agents. Better to avoid steroids because once you give the steroids, the true picture is not seen by the rheumatologist. So better to avoid steroids and start NSAIDs and refer early. So this is just to show what rheumatoid arthritis can do. The next case is a 32-year-old male without comorbidities. Is presenting with back pain with early morning stiffness, 3 years duration. He's also complaining of alternating buttock pain, and there's history of heel pain and painful swelling of right ankle joint. So on examination, there is restricted spinal mobility, and there is sacroiliac tenderness. And he also has Achilles tendinitis and ankle joint synovitis. So what is inflammatory back pain? Just a few words. So there are a few features to recognize inflammatory back pain. So usually the age of onset is less than 40 years of age, and it's of insidious onset, and it tends to improve with exercise, and there is no improvement with rest. And the patient may have pain at night, may even wake up in early morning with the pain, but after rising and moving about for about half an hour or 1 hour, then the pain and the stiffness eases off. So these are the features of inflammatory back pain, but it's a bit difficult to determine whether it's inflammatory or non-inflammatory. So this is just a picture showing Faber's test to determine sacroiliac tenderness. The other one is showing the Schober's test. I'm sure you all know this. So here again to show the importance of the pattern of joint involvements into for diagnosis of arthritis. So here the inflammation of axial joints is seen, and there's asymmetric oligoarthritis. Then there's dactylitis. Dactylitis is when the whole finger is swollen due to involvement of the joints as well as the other tissues like the tendon sheath and the ligaments. And they also have enthesitis. So here we a few words on spondyloarthritis. There are a few types. Just to recap, there's ankylosing spondylitis, that is the classic type, and then we have the non-radiographic axial spondyloarthritis where we don't see the classic X-ray findings. Then there's the peripheral spondyloarthritis where you don't have the majority involvement is the peripheral joints where there is no involvement of the spine. And reactive arthritis, then arthritis associated with inflammatory bowel disease and psoriatic arthritis. And of course, we have the undifferentiated spondyloarthritis. So it's an X-ray showing bilateral sacroiliitis and a bamboo spine, which is seen mainly in ankylosing spondylitis. So investigation-wise, we can order an MRI to detect active sacroiliitis and spondylitis, and inflammatory markers are usually high in active disease. HLA-B27 can be used to assist the diagnosis. So now it's just to say that now we've discussed several cases where the number of joints involved and the distribution of the joints helped us in the diagnosis of the particular arthritis. So just to recap, monoarthritis is when a single joint is involved. We see that in septic arthritis, gout, even in spondyloarthritis and osteoarthritis. Oligoarthritis is when there is 2 to 5 joint involvement. See it in spondyloarthritis, osteoarthritis, and gout. But it doesn't mean that rheumatoid arthritis can't present with oligoarthritis. It can, but it is predominantly is a polyarthritis. So if we see polyarthritis, you have to think of rheumatoid arthritis, nodal osteoarthritis, spondyloarthritis, and also psoriatic arthritis. So involved joint, if the predominant small joint involvement, we have to think of rheumatoid, nodal osteoarthritis, and psoriatic arthritis. If there is metacarpophalangeal joint involvement, it's more likely to be rheumatoid arthritis. If there's distal interphalangeal joint involvement, then it's likely to be nodal osteoarthritis or psoriatic arthritis. And sacroiliac joints and spinal involvement, then we think of spondyloarthritis. If there's symmetrical involvement, we think of rheumatoid arthritis and also arthritis associated with other connective tissue diseases. Just some pictures to show. The first picture showing spindling of fingers, involvement of proximal interphalangeal joints symmetrically, and the other joint showing first metatarsophalangeal joint. The other two hands showing distal interphalangeal joint involvement with nodes, and you can see some proximal interphalangeal joint involvement as well. That's a hand with nodal osteoarthritis. So the next case is a 38-year-old male who's coming with acute painful swelling of bilateral knee joints, painful toes, which on examination was found to be dactylitis, and he has a scaly rash on the scalp. And when looking at the nails, you can see nail pitting and early onycholysis. So here we see this is a picture showing dactylitis of the fingers though, and a plaque the elbow with a plaque psoriasis, and then nails with psoriatic changes. So here we looked at the associated features. So the patient had psoriasis, and the joint involvement is in keeping with psoriatic arthritis. The diagnosis here is psoriatic arthritis. So then looking at the associated features, it can help us to come to a diagnosis. So we have to look at the skin, so to see if there's any malar rash, DLU, subacute lupus erythematosus, then hair loss, whether there's psoriasis, whether there's pyoderma, vasculitic rashes, rheumatoid nodules, or gouty tophi. So these will help us come to a diagnosis. It's just a picture showing a malar rash, and oral ulcers, and a subacute lupus rash in a patient with SLE. Here a picture showing some gouty tophi of patients with tophaceous gout. So in the eye, to look for scleritis, episcleritis, and uveitis, and inflammatory bowel disease, have to ask for those features. And then we have to look for other systemic involvement that would also help us to come to a diagnosis. So the next case is a 23-year-old lady who presents with painful swelling of fingers for 2 months duration, and we find that there is tender and swollen proximal interphalangeal joints. She also has hair loss and fatigue. Examination reveals cervical lymphadenopathy, and blood pressure is 150 by 100. So here the investigations are important. We did the investigations, showed anemia, low platelets, and there's leukopenia with lymphopenia, and the UFR showed protein, and there's raised ESR with modest elevation of CRP. So with these findings, classic of SLE, so we have to diagnose SLE in this patient. So here the investigations became important. So what I wanted to, so if you are suspecting SLE, we need to do an early assessment and refer to the rheumatologist. So we may have to arrange autoantibodies, ANA. Depending on the clinical features, we have to go for the other antibodies. And these are actually a bit expensive, so depending on the clinical features and suspicion only, we tend to order these. And if you are in doubt whether there's a acute flare, or to determine whether it's there's infection complicated, then we can go for complement levels. And these of course will be done in the specialized clinics. And then we have to evaluate for the involvement of other systems and organs. And sometimes we may have to go ahead with antiphospholipid antibodies as well. So just to show that investigations are important in evaluation of joint pain. So investigations should be carried out for diagnosis, and to look for complication, and for management decisions, and to assess the patient's general status. So we have to arrange for basic investigations like full blood count, liver function test, renal function test, UFR, and inflammatory markers. And then there are specific investigations where we have to do serum uric acid, rheumatoid factor, anti-CCP antibodies, ANA. When we are requesting ANA, better to go for indirect immunofluorescent assay rather than going for ELISA, because ELISA has less sensitivity. Then ANCA, that is also if we are suspecting a vasculitis only, otherwise we should not go ahead and order all this because they are very expensive. HLA-B27 and serum complement levels. So imaging is important, X-rays, but X-rays, of course, X-ray findings are later in the illness. But in the early arthritis, X-rays are not that useful. So ultrasound scan is used to determine the structures involved. So sometimes when we are not sure which structures are involved, then we can use that. And then to detect acute inflammation. Sometimes if we cannot detect acute inflammation clinically, if there is no significant swelling, but the patient is coming with symptoms in keeping with inflammatory arthritis, then we can use ultrasound scan with Doppler studies to see if there's acute inflammation. And ultrasound can be used to detect any tendon ruptures and so on, and also sometimes to exclude tumors. MRI is used to detect, to see whether there's active sacroiliitis and spinal involvement. And then we can also use MRI of the joints to detect active inflammation, but here we don't use it much for that purpose. Then CT scan can be used to exclude chronic infections and malignancies which are mimicking arthritis. So synovial fluid analysis is important to exclude infections and also to detect inflammatory arthritis and also to detect crystals. As I said, we can send fresh samples for polarized microscopy or discuss with the pathologist and send for crystals. And synovial biopsy in specific times when we can't determine which type of arthritis it is, to differentiate sometimes from chronic arthritis like infections. So just to touch upon the principles of care. So there is symptomatic relief with analgesics, anti-inflammatory medicine, and steroids. You can give either oral or intraarticular. Physiotherapy, splinting for symptomatic relief, and disease-modifying agents and immunomodulatory therapy if necessary in inflammatory arthritis. And to improve functional status is the next goal, that with physiotherapy. Then you can use orthosis and devices, and surgery can be helpful. And patient education and self-help is also very important in this. Thank you.
Thank you, Asanka, for that very comprehensive lecture. Can we have some questions? Does anybody have any questions? Asanka, the sacroiliitis, since we don't have easy access to the MRIs, can the X-rays help in any way?
Yes, we can detect sacroiliitis, chronic sacroiliitis on the X-ray. But MRI is to see when there is no X-ray changes, and also to determine whether there is active sacroiliitis if you are suspecting that.